highest risk group are those patients who are previously treated and have a 17p deletion. But my opinion is that the 17p untreated population, which is a small minority of patients going on frontline therapy, it's about 5 to 8% of those patients. The outcomes with standard treatment, if they can tolerate chemoimmunotherapy like FCR, their first remission is very short, so it's on the order of 14 months with FCR, if they can tolerate FCR. The majority of them don't get complete remissions, and their disease is not held in check for very long at all with that standard treatment. Unfortunately, we don't have a large experience with a 17p deleted untreated patient with population with ibrutinib, but I think that would be a population, if I were to consider any frontline group to use ibrutinib for, it would be the patients with untreated 17p deletion. And that is because so far the early data that we do have with ibrutinib indicates that in the relapsed population, clearly it's an advance and improves on their survival. And I think we'll eventually have data in the frontline setting for the 17p population. But my opinion is that there's no standard treatment for a patient with 17p deletion, whether they're able to tolerate FCR or Campath or Campath plus steroids. And certainly if they're not able to tolerate FCR, and a treatment option would be a combination like obinutuzumab, chlorambucil, or some other combination. They're not going to do well. They don't do well with standard treatments that we use, chemotherapy or chemoimmunotherapy-based treatment.